Door to Unload STEMI pilot study is built on the premise that heart attacks lead to heart failure. And heart failure after a heart attack is correlated directly with the size of the heart damage. And so reducing damage to the heart or infarct size is the ultimate objective of the Door to Unload program. And now the Door to Unload STEMI pilot is also based on 4 decades of preclinical science that's been extended now from across a spectrum of heart pumps. And what we've learned over those decades is that in order to reduce infarct size, we have to first adequately unload the left ventricle. So the term unload, which is in the title of the trial, what that means is we have to reduce the amount of left ventricular work and the amount of wall tension, the wall stress of the ventricle. The second component of unloading and the work that's been done in the preclinical arena is that you have to unload before you reperfuse the artery. So in contemporary practice, the only way we can shut down ischemia or reduce the burden of a heart attack from getting worse is to open the artery as quickly as possible. And the problem with that is that after you open the artery, there's still a lot of damage. And actually, in fact, the damage gets enhanced by something known as reperfusion injury. So with the preclinical work suggesting that you have to first unload and then you have to potentially delay reperfusion, the purpose of the pilot study was to test whether or not translating that preclinical concept into patients is, first of all, feasible, is it safe, and then to identify, is the 30 minutes really necessary? Is there any sign that that might affect the size of the infarct? And so that was the fundamental rationale for doing the pilot study. A lot of people have asked the question of why there wasn't a standard of care group as a comparator, meaning without LV unloading. And when we're designing a pilot study, this is a phase 1, so we're not really comparing it to the current practice. What we want to do is first test in a sort of a dose response mechanism, unload versus immediate reperfusion versus unload and delayed reperfusion. And the advantage of doing it that way and unloading all 50 patients that were in the trial is that we also get to study safety and feasibility in the total cohort of 50 patients since they all received the intervention. So the study was designed as a 1-to-1 randomization to those 2 arms, unload and immediate versus unload and delayed reperfusion. And the readouts of feasibility and safety were, first of all, successful enrollment and protocol completion. And then also at safety, we used 2 parameters. One is 30-day MACE, major adverse cardiovascular and cerebral events. And the second readout was also infarct size. And so for the first component of completion of the study, we were proud to announce that we actually, across 15 centers with multiple operators, were able to successfully complete enrollment, that all 50 patients were able to be unloaded with the Impella device. We also importantly saw that with operator behavior, in the group that got randomized to 30 minutes of delayed reperfusion on the platform of Impella unloading, that there were 0 bailout. So not one operator, all of them had the opportunity to bail out at any moment, bailed out and performed PCI earlier than the 30 minutes of unloading. And to me, that's one of the critical messages of the study towards feasibility and early signs of safety. And the second component that we looked at for safety around MACE, the MACE event rates were low using traditional MACE definitions at 30 days. And even with the addition of vascular events, which is not a traditional MACE definition, we also saw that events rates were low, again, confirming safety of this approach. And then for the final point on infarct size, when we as operators are thinking about infarct size, we know from historic studies that for every 30-minute delay to reperfusion, there should be a 7.5% increase in the infarct size. So the goal of the study was to show or to see whether or not imposing a 30-minute delay, but on the platform of unloading, caused this 7.5% increase. And we were very excited to see that there was no significant increase in infarct size with unloading and delayed reperfusion compared to unloading and immediate reperfusion. And in fact, in a small subgroup exploratory analysis, we found that in patients having larger heart attacks, unloading and delaying reperfusion actually led to a statistically significant reduction in infarct size compared to unloading and immediate reperfusion. So all of the information from the pilot study should be taken as lessons learned. We don't want to make any conclusive statement other than it's feasible and it's safe to unload a patient before reperfusion, even with a 30-minute delay to reperfusion. And I think that's the ultimate take-home message from the pilot that now informs the development of a pivotal trial, which will now have a two-arm execution. One is standard of care, door-to-balloon approach, versus door-to-unload. But now with the lessons from door-to-unload STEMI pilot, we've learned that that arm is going to be unloading with a 30-minute delay to reperfusion, trying to capture that early sign of efficacy that we observed in the pilot study.